Well, today we're fortunate enough to have Dr. Thomas Odorizio from the University of Iowa, a long-time proponent of certain excellent therapies for NET patients. And Dr. Odorizio is here today to speak with us about blood markers and why it's so important to follow them for NET patients. So welcome, Dr. Odorizio.
Thank you very much, Bob. And I would like to thank Bob and Marianne for this wonderful opportunity to, if you will, come off the bench and be able to give a conference to the NCAN support group, which holds a very special place in my heart and over the years. Today, I thought, and I've put this together with the support group in mind, and I've had a chance to review it from a couple of different angles. But the thrust of today's talk, or what I'm going to share, is on what I call functional biomarkers. And these are the blood tests that our center, I know Dr. Woldering and Maluccio's center in LSU Ochsner does the same thing, and I believe Mayo has started to do some of the sample collections, but we've been doing these for many, many years. And from observations made by our multidiscipline team, it has become apparent that some of these biomarkers, in addition to being functional hormones, which when they're secreted in high amounts associated with certain tumors, nets, that they offer symptoms and syndromes. But we also have identified at least two of these markers which have prognostic value. And we have come to use this on an almost visit-to-visit basis to be able to discuss with the patient. The markers are showing a trend here or here, and we need to pause and consider perhaps another different therapy. As you all know, there are several wonderful therapies available, and choosing the right therapy at the right time is the trick. But these markers have come to guide us when it's prudent to think perhaps earlier that an intervention at this time might be appropriate. So I've designed this to show a patient, show the impact that it has had on the patient, and then to share with you a little bit of the principles regarding these neuropeptides. And they, for the most part, are neuropeptides, which act like hormones. They're not the classic hormone that you think about when you think about testosterone or estrogen, but these are another set of hormones that do the same thing. Namely, they're released, they travel to another tissue, and they exert their action on another tissue in a very small amount. It doesn't take a quart or a pound of this material to cause a symptom or a syndrome. And that is why it exists. These hormones exist, or these, I call them biomarkers, exist in very small amounts. So let's begin with the patient. Patient M.D.G is now 36, presented with a 3-year history of constant facial flush, loose stools daily, numbering 4 to 6, that would end around 12 noon or 1 o'clock, right flank pain, and some almost asthma-like shortness of breath. His diagnosis was established as a neuroendocrine tumor in 2012. An Octria scan done way back then, that was 8 years ago, showed somatostatin receptor avid liver lesions and lymph node lesions. He had a cardiac echogram which showed right-sided valve involvement, tricuspid and pulmonary, which you're all familiar with can happen with an ileal carcinoid. He had surgery of the primary tumor in 2013 by our colleague at Iowa, Dr. Jim Howe, and a CT scan done about a year and a half later showed that he had about 60% liver tumor burden. He underwent 4 cycles of PRT using the 177 lutetium, or Lutathera, which you're all familiar with. And then, following that, even though his liver lesions were stable, the liver transplant people determined that he was a good candidate for a liver transplant, and he underwent a liver transplant in 2017. This is a table of the average of 3 visits of his different biomarkers before the liver transplant, and an average of 3 visits after his liver transplant, and then one done more recently in March of 2020. Please note his serotonin, which was expected to be very high, was indeed very high. Following liver transplant, it returned to almost near normal. In our test, it's 200, and in some assays, Mayo, for instance, it's 225. But he had an enormous, dramatic reduction in his serotonin with the liver transplant. His Chromogranin A as well reached almost normal limits following transplant. His Pancreastatin was the most remarkable to us, which was sky high over 3 visits before the transplant and returned to normal. And his substance P, which we also collect, because substance P is a biomarker that co-releases with serotonin when you're dealing with ileal carcinoids, namely that it's co-released with the serotonin and has virtually the same action in high amounts of flushing and secretory diarrhea. If you'll notice to the far right, these are many months later, was his serotonin had gotten lower. His Chromogranin A now with a normal level of 160 on that assay was now normal. Pancreastatin remained well within the limits of normal of 135. Neurokinin A, which was well under 50, and you all know the significance of neurokinin A as a biomarker, portending for shorter lifespan when it's over 50. And his substance P actually returned and stayed in the normal range of under 260. Well, let's go on to the characteristics of neuroendocrine cells and their respective tumors. Neuroendocrine cells take up a precursor called tryptophan. It's an amino acid. So if there's anything that you want to avoid when you have an ileal carcinoid or a small bowel neuroendocrine tumor, it's a tryptophan derivative, because that can cause the synthesis of more serotonin. So you're just stoking the fire with an amino acid over the counter, which you don't need. These cells, by their nature, synthesize. That is, they make these biomarkers, they store them, and they release both single amino acids, such as serotonin, and neuropeptides, such as gastrin, substance P, if you will, Chromogranin A, and they all, or at least 92% of them, express the receptors specific for somatostatin receptor subtype 2. They also they also express transporters, and those transporters would be like norepinephrine transporter, and that is why a scan like M.D.G may be positive, because certain of the small bowel tumors express the transporter, which is like a receptor but a slightly different membrane structure. And they are distinct cytologically, but they virtually all make chromogranin A and synaptophysin. And these two stains, if you will, or these two proteins, neuropeptides, define the essence of a neuroendocrine cell. So an excellent pathologist can identify a neuroendocrine cell by looking at the structure, but the stains seal the deal in terms of identifying it as a neuroendocrine cell-derived tumor. What are the problems with neuroendocrine tumors therapeutic interventions? Well, the decisions for these are made primarily on the gold standards you're all familiar with. That is CT, MR, even ultrasound demonstration of disease progression. So those three define if a tumor is growing. And it is the CT, MR, or ultrasound demonstrating progression that establishes in a standard way your next step for therapy. And the other thing to keep in mind is that symptomatic and asymptomatic changes are subjective. Some folks have extremely high thresholds to even things like abdominal pain, where they really don't even recognize that they have a symptom of abdominal pain. And it's just the nature of people, and other people would be able to almost define precisely where a pain pattern is actually beginning, and and that has to do with their perception of themselves. But I always say these changes are a little bit like art, in the eye of the beholder, and the beholder is always right. Now, there's tumor secreting amines and neuropeptides, and this is the real trick that you must remember. These tumors, by their nature, if they're going to make a biomarker or a hormone, if you will, too much of a good thing, a hormone, they will initially make it, and then it'll go away and behave normally. And in the early stages of almost all the neuroendocrine tumors that have symptoms, think of an insulinoma with sudden release of insulin and low sugar. Think of gastrin suddenly being released with dyspepsia, heartburn. It'll happen, and then the hormone will go down in the bloodstream. But as the tumors grow, they become more chronic, they become more elevated, and the levels stay high. And that's when you know that the tumors may have spread, and so you're bathing in the hormone, if you will. The best example would be something like serotonin. Over time, the serotonin levels stay high and achieve elevation and stay elevated in the blood. What are the basic principles of neuroendocrine tumors? These syndromes and symptoms, such as the symptom of low blood sugar, are due to sudden and then sustained levels of circulating peptides, such as amines, such as serotonin, catecholamine, or even neuropeptides, such as insulin, VIP from the pancreas, excess gastrin from the pancreas, excess glucagon from the pancreas, and these are all associated with functional tumors. Documentation of elevated amines and neuropeptides, these biomarkers, if you will, many of which are functional, should be done whenever possible. And that is what we're about today, to talk about the the very importance of them, but also things that you should want to follow, like many and most of you do when it comes to the Ki-67. You're extremely keen and knowledgeable on what that means. And these biomarkers need to be impressed the same way, so that a physician attending you in a clinic with expertise in neuroendocrine tumors should be able to tell you and interpret what these mean in your case as you come back and forth, and these values are drawn on every clinic visit. These are the biomarkers in their neuroendocrine tumors. I'm just reminding you of these that are associated with the tumors that some of you have or many of you have. When it comes to the small intestine carcinoid, usually in the ileum, the main biomarker is serotonin, but they can also make neurokinin A or be associated with elevations of neurokinin A and substance P. The basic markers for tumor burden are chromogranin A and its fragment, pancreastatin. We'll talk to that down the road. There's carcinoid of the lung. Pardon me a second. Carcinoid of the lung is considered the foregut-derived neuroendocrine tumor. And again, chromogranin A is the principal marker for following these. Pancreastatin is also very important when the tumors go to the liver. Serotonin, on the other hand, is not that relevant in a carcinoid tumor of the lung because there's just not that many serotonin secreting cells. But it can occur in about 3 to 5% of the patients, and you can get a carcinoid-like syndrome. When it comes to neuroendocrine tumors of the pancreas, in general, chromogranin A and pancreastatin are very important, and these have been shown and published, and that's the point I want to make. These become very important functional markers because they tell a story about tumor burden, or they tell a story about overall survival, or they can tell a story about progression-free survival and even progression. And that's why the pancreastatin especially is so important. There's non-functional tumors, which are the vast majority of the pancreatic tumors. And for non-functional tumors, you should have at least one pancreatic polypeptide, one calcitonin, and even serotonin, because there are many, probably 40 or 50% of non-functional tumors of the pancreas may be associated with moderate increased levels of serotonin, which can be associated with episodic diarrhea in so-called non-functional neuroendocrine tumors. Regarding the functional ones, you follow with the tumor that they're secreting the most hormone of. For instance, insulin-secreting tumors secrete insulin. Gastrin-secreting tumors secrete gastrin. Glucagon. Now, this is a particular slide, which I put together. Much of it's from actual hands-on experience, but I think we can make the point about the nature of these functioning biomarkers as tumors begin to grow and as they become more metastatic, and their product, their hormone product, their neuropeptide marker ability becomes sustained. And if you look there on the table, it says acute excess and chronic excess. So the acute excess, and especially serotonin, is beautiful because you can know the 5 E's: excitement, ethanol, exercise, even eating will stimulate the release of serotonin. And when I look at acute excess for serotonin, I think of when I was sitting there in Wyoming watching Old Faithful, and everybody else was sitting around me. And we waited, and then Old Faithful went off, as it were. And as it was shooting straight up into the air, it was falling like a waterfall at the same time. And that's exactly what acute excess biomarkers do. When they're suddenly released from a tumor, they're stimulated, they go up for 35 to 40 seconds, it starts to break down, and the event becomes lasting a minute or 2 minutes. On the other hand, when serotonin is chronically elevated, you see mostly the diarrhea and the perspiration associated with it. One more thing about acute excess of serotonin: your blood pressure can drop to the floor for 30 or 40 seconds. Associated with that can be lightheadedness and a profound flush. Regarding substance P, that's almost the same phenomenon. A sudden release of substance P in the body can cause a flush and hypotension, but because of its short survival, once it goes up, because it's decaying at the same time, it'll last maybe a minute or two. On the other hand, when you have high levels of substance P all the time, you get secretory diarrhea, just like serotonin. For gastrin, believe this, a sudden stimulation of gastrin, which can happen, can cause a flush and a feeling of profound reflux of acid when it's acute. When it's chronic, you get atypical ulcer formation in the stomach and duodenum, and the folds in your stomach can become thickened over chronic stimulation. With insulin, a sudden excess is symptomatic hypoglycemia, and many of you may have witnessed that, especially if you're diabetic and taking insulin. That's one of the side effects of insulin. Too much insulin is symptoms of low blood sugar with shaking, tremulousness, pending doom, and a feeling of hunger. On the other hand, when insulin is chronically elevated, you start to experience effects on the brain called neuroglycopenia. And so on down for glucagon, acute and chronic excess. So this helps a little bit. So and the other thing it reinforces for folks that suffer neuroendocrine tumors that have symptoms is that it's not in your head. These are physical things that happen with hormones that exist in very small amounts in your body that do very important actions normally. And when they're suddenly stimulated, if they're important physiologically in your body, they're going to be exaggerated with an episode of a sudden release of any one of them. And so you must know that you're not making, it's not, this isn't something it's in your brain or your mind. This is real time. And you now should understand that they're short-lived and that the episode should start to self-regulate. Let's look at a moment again of serotonin and carcinoids. Where is serotonin most concentrated in the neuroendocrine cells? It's most concentrated in the the neuroendocrine cells of the small intestine. If you look at where those cells are, they're right smack in the end of the small bowel, in the ileum and a little in the jejunum. So it's no surprise if you make a tumor there, a neuroendocrine tumor, it's going to be predominantly rich in serotonin and frequently associated with the carcinoid syndrome. On the other hand, foregut carcinoids in the stomach and lungs have very few serotonin granules. So it's not going to be necessarily revealing high levels of serotonin in those tumors that begin in the lung or the stomach. How about hindgut carcinoids? Very few serotonin granules. So it wouldn't be surprising if when you had a biomarker profile that your serotonin in those areas may not be rich or high. Obviously, there's exceptions. Large bowel carcinoids can have serotonin deposits. And for pancreatic nets, serotonin can be elevated in the bloodstream. So what am I saying? You would like a serotonin in your biomarker profile if your serotonin is elevated when you first are diagnosed. Regarding whole blood serotonin, there are several CLIA. That's a certification for commercial labs, and the American College or the College of American Pathologists that are approved in the United States. There are at least 5, and remarkably, their upper limit of normal in all 5, normal serotonin in our bloodstream, is very close to the from one to the other. And the trick with serotonin is being able to preserve it, because you can't, once you draw the blood, if it's not put in ice immediately, technically, it breaks down very quickly and you end up with a 0 level. And sometimes that becomes an artifact created by improper collection. But almost all good labs at the universities and in hospitals know exactly how to draw these tubes for preservation and measurement. Let there be no doubt. Serotonin goes back a very long way, and when they started to add ascorbic acid to the whole blood, they were able to preserve serotonin for long periods of time. And this one paper from Clinical Chem in 2000 makes the point. It has a positive predictive value of 89% for carcinoids and a negative predictive value of 93% for midgut carcinoids. So it's extremely sensitive and specific. In and of itself, it may herald a tumor, but because it sees it so quickly in the bloodstream with such sensitive amounts that you may not see the CT catch up with it for a period of time. And even the gallium-68 can DOTA net spot test may miss it because they're too small to be seen. And again, chemist paper also in Clinical Chem in 1994 showed that in ileal carcinoid, serotonin is measured elevated in the bloodstream in 96% of the cases. So the collection is done automatically once it's ordered by your lab people. It's the most sensitive, but remember, it's episodic. It can sometimes release in high amounts if it's stimulated, and it'll come back to normal in a minute or two. Regarding the 5-HIA, which is a metabolism of serotonin, it's cleaved by an enzyme. It almost never is elevated without liver metastasis already there, with a tumor burden of about 15 to 20%. So collecting a urine in the very first stages of symptoms of carcinoid for serotonin is usually not very valuable, unless, of course, the carcinoid is already in the liver. And that doesn't, fortunately, happen 100% of the time. Furthermore, we have a plasma 5-HIA. As Dr. Gene Woldering always says, you no longer have to lug a jug for 24 hours. You can now just measure the blood level and get the same high degree of correlation with a 24-hour urine 5-HIA called a plasma 5-HIA, and it has an excellent correlation of not quite 1-to-1, but of 0.8, which makes it very highly correlative with the urine 5-HIAA. Chromogranin A has a long history. It's a very long history. It began in Europe. And Europe were some of the very first after the discovery of the Chromogranin A family by D.T. O'Connor from San Diego. Antibodies were made, and they were able to study it with a test, an assay, if you will, and could measure it very easily in the blood. It's a very large peptide. It's stored in secretory granules of both nervous system and neuroendocrine cells in tumors. And it, most importantly, Chromogranin A, I think of it as an earth person that you can break a little bit or cleave. Cleave is CLEAVE, and it's cleaved by an enzyme called prohormone convertase 1, and it breaks off a piece of itself, or the enzyme breaks it off, and it becomes pancreastatin. So pancreastatin comes from a fragment of chromogranin A. And I put the units up there so you'll know the difference. When you're measuring chromogranin A, it's like, I don't want to be too crude, but it's almost like measuring, a pound of dirt on a scale. And it's measured in nanograms, which is 10 to the minus eighth grams, 10 to the minus ninth grams. But when you measure pancreastatin in the blood, in its functional levels, it's measured in picograms. That's 10 to the minus 12th grams. That's hugely different, hugely much smaller, if you will. And so pancreastatin has to be measured by a specific kind of assay. And we're very fortunate in the United States that there had been 3, and now there's 2 great commercial labs that provide the pancreastatin assay that get the samples from all the wonderful large referring labs like Quest, LabCorp, ARUP. These all send a specific test for pancreastatin, and they do the chromogranin A themselves. But chromogranin A, still to this time, needs to be considered an accurate marker of neuroendocrine tumor burden. Although crude, it still is an accurate marker for when there's tumor growth, if the tumor growth is appreciably enough. And also metastasis. It can warn for metastasis when a tumor from the pancreas, a functioning pancreatic tumor, goes to the liver. And in that regard, the most important thing to remember about the chromogranin A, especially, is when is getting it drawn from the same lab, or making sure your physician is sending it to the same lab, because a lot of times the difficulty is in what is normal in one lab for chromogranin A may not be normal in another lab for chromogranin A. That's not so the case with pancreastatin, because it's remarkably similar from lab to lab. Just a slide and a note of neurokinin A validation, both in Europe and the United States. This paper was remarkable in that the senior assayist, Dr. Joy Ardill from Belfast, Ireland, split samples with Inner Science Institute in California, and they independently measured neurokinin A with their own assays, again using split samples crossed back and forth. And the results were remarkable. The absolute outer range point beyond which a prognostic value to neurokinin reached was 50 picograms per mil, again in the 10 to the minus 12th. And what they showed, and that's nanograms per liter, picograms per mil, but what they showed was remarkable. And this is the cumulative one from the United States, but Dr. Ardill had shown it in Europe. When a person with small bowel tumor comes in with a neurokinin A greater than 50, shown in the red dotted line, the cumulative survival probability drops. On the other hand, when they come in with a normal neurokinin A, less than 50 picograms per mil, their cumulative survival probability takes a relative, natural course, as you can see. But if you can bring the neurokinin A back to below 50 on a person who is elevated when they come in, they assume the same curve as the green curve. And that's the hopefulness and the effort and the understanding when you have a neurokinin A from the small bowel tumors. Seems to be unique for small bowel tumors. But neurokinin A is followed serially, and Dr. Woldering has since published again a very large series, as has Dr. Ardell, and the message has remained the same. Just one slide on pancreastatin. Pancreastatin is a remarkable, as we will see in a moment, biomarker, which I call functional. And the best assay, of course, I'm not too biased, as you can see in the lower right corner, but the best assay was designed by Inner Science Institute in let's see, Glenwood, pardon me, I'm thinking California, and it's called Inner Science Institute. But be that as it may, this is a patient Dr. Gene Woldering had, and that black vertical line shows what happened with surgery when both 5-HIA and Chromogranin A were very unhelpful versus pancreastatin. You could see it rising from a small amount. Again, this is in picograms per mil, but went up to almost 300. Surgery, debulking surgery of the liver, drove it down, and those are dates that go in months, and for the most part stayed relatively constant, and then started to progress again, and the pancreastatin had made the call in virtually every time point where there was progression. So it had enormous sensitivity for picking up progression, but this study did not look at progression as an outcome. These next two papers and my last two papers make the point, which I feel are seminal papers, and these papers were done by the senior investigator, Dr. Howe, at our university, and their fellows, Dr. Sherman and Dr. Maxwell. He had, and his title is the title, Pancreastatin Predicts Survival in Neuroendocrine Tumor Patients. He had 98 small bowel neuroendocrine tumors and 78 pancreatic neuroendocrine tumors. He had event times that were estimated by the very well recognized Kaplan-Meier calculations, which looks prospectively at progression-free survival and overall survival in a patient who has survived and proceeded with their tumors. And he did a pre- and post-operative set of the neuromarkers for correlation with outcomes. So he looked specifically to see if CGA, pancreastatin, neurokinin A, if any of those biomarkers had a predictive or a correlative value with the outcomes, such as overall survival, progression-free disease. Used multivariate Cox model adjusted for confounders, and this is important. Age, a stage of the tumor. He made sure that there wasn't one particular stage that was affected, and the reason it was affected was because it was a different stage, a different sex, etc., etc. His results were striking. It showed preoperative serotonin was associated independently with progression-free survival. So preoperative high levels or normal levels predicted better survival when they were normal. Postoperative reduction of serotonin, however, significantly associated with better progression-free survival. So you hear the theme. When these biomarkers are abnormal, an intervention can, and you can change them with an intervention, you're doing a great service, and the patient can see physically what the therapy has done for them. Preoperative chromogranin A and preoperative pancreastatin both showed significant correlation with progression-free survival and overall survival. So there again, just the high levels before the surgery predicted the progression-free survival. Elevated pancreastatin was associated with a shorter median progression-free survival and overall survival versus normal pancreastatin. And these numbers held up. For instance, elevated post-op pancreastatin 5-year progression-free survival dropped way to 8.6%, and overall survival decreased to 6.5 years versus the one above, which gave you a much higher progression-free survival if it normalized after surgery. Their conclusion was higher pancreastatin is associated with progression-free survival, and that is a lower progression-free survival and overall survival in both small bowel ileal carcinoids and pancreatic neuroendocrine tumors. And as you know, with confounders, it was independent of age, primary tumor site, and nodal or metastatic disease. This is the final paper I'm sharing with you. It's again done by Dr. Howe with the fellow Dr. Tran. And he says it the way it is. It is time to rethink biomarkers for surveillance of small bowel nets. In this case, he had 218 small bowel tumors, which had nodal metastasis and 73% metastatic. The biomarkers he measured were serotonin, chromogranin, neurokinin A, and pancreastatin. And he used just the upper limit of normal or beyond the upper limit of normal for an abnormal value. It's important to know that when you do these assays, when you have a range point given, the upper range point represents 2 standard deviations above the mean, so that would put it at 95% confidence that that's within normal limits. He also again looked for confounders, as he did on his other paper. His results were striking. Pancreastatin showed superiority with a 79% accuracy versus chromogranin A in determining progression. And we have seen it repeatedly. One of the most dramatic was a lung carcinoid that we were following for 5 years. And the pancreastatin came back from normal to elevated. And at that time, the progression to the liver was suspected, and 2 weeks later, the liver CT indeed showed metastasis from the tumor. But this is how he looked at the marker in relation to correlation with the outcome, and it's remarkably accurate versus chromogranin, which has a less percent accuracy, due in a large part to the various comorbidities that are associated with elevations of chromogranin A, such as hypertension and renal disease. In conclusion, Dr. Howe and Dr. Tran concluded that during long-term follow-up, pancreastatin accurately detected progression, and that it should replace CGA for small bowel surveillance. One more paper, I apologize, was elevated pancreastatin was an indicator of hepatic metastasis in patients with small bowel tumors. And this was done with authors that included Dr. Warner from Mount Sinai, the grandfather and great-grandfather of neuroendocrine in the neuroendocrine field. And that was published in 2015. And what he showed, they looked retrospectively at 77 patients, 44 with primary small bowel, 49 with metastasis to the liver. They looked at the metastatic markers, Pancreastatin and Chromogranin A, for sensitivity and specificity in detecting liver metastasis. And their results showed that Pancreastatin had an 87% sensitivity for predicting when the tumors went to the liver, and a negative predictive value of 83%. So highly specific as well as highly sensitive as well as specific versus chromogranin alone. In conclusion, that's the conclusion of the paper from Dr. Warner. Elevated pancreastatin is a sensitive and specific assay for detecting the incidence of metastatic disease of small bowel and tumors, and routine measurement of pancreastatin is supported for NETs. In conclusion, biomarkers, we hold to these three. Chromogranin A can reflect total burden when metastatic for pancreatic and midgut ileal neuroendocrine tumors. Neurokinin A is a predictor for aggressive midgut ileal tumors, and pancreastatin may be a very early marker for liver tumor activity and predicts progression-free survival, overall survival, and progression. And when therapeutic intervention lowers that to normal levels, it reverses the negative trends. And that's something all of these you folks, I want you to bring home, that this is not a hopeless story. This is a very hopeful story, because it tells your physicians that they have to start moving on your other therapeutic options. These are the labs in the United States that support the various tests that we've talked about. They're all commercial. They're all confidential. You're given a number. The number is measured. The number representing your name value is returned. And that's the way commercial assays work. And there's a vigorous monitoring and surveillance systems of CLIA that allows labs to take blood from across state lines to be able to measure these assays for the United States. A very rigorous process. Quality control is very strictly tested 4 times a year. I had the fortune of running the neuropeptide lab for 25 years at Ohio State, and I can tell you that it's very rigorous in the criteria to maintain a lab for interstate measurement of blood samples. I think I'm going to stop there, and I'm going to thank the members, the Waymans and their staff for this wonderful invitation. And I thank the viewers, the support group, and the patients for attending. I appreciate it very much, and I wish you all peace and a safe holiday.